Very good morning to all. At the outset, I would like to thank Dr. Manavi Madam for giving this opportunity. So I'll be talking on ocular and systemic investigations in diagnosis and management of endophthalmitis. So endophthalmitis, can be classified into exogenous, which might be post-operative or post-traumatic, and endogenous, which will be hematogenous. And etiology-wise, you can get the gram-positive bacteria, the most common. More than 70% of them are gram-positive, and most common is staph epidermidis for post-operative endophthalmitis, and the coagulus negative staphylococcus. And then we have the gram-negative around 10 to 15%, pseudomonas being the most common, followed by fungi, which is around 3%. So coming to the ocular evaluation, the clinical features, the symptoms which the patients present with, pain is the most pathognomonic finding for endophthalmitis, and however, it can be absent in 25% of cases. Then the patient will present with the blurring of vision, photophobia, watering and redness of the eye. So the common signs which you have to look for is decreased visual acuity. You have to check the vision of the patient and then look for any lid swelling. So conjunctival chemosis. So this lid swelling and conjunctival chemosis is two findings which are important to differentiate from other causes of redness in the eye. It might be an uveitis or conjunctivitis, or lid swelling and conjunctival chemosis mostly will be seen in cases of endophthalmitis. And then corneal edema, anterior chamber cells and flare. Again, hypopyon will be seen in most of the patients, which will be a cardinal feature. And vitreous inflammation, retinitis and blunting of the red reflex. And retinal periphlebotitis can be seen in some cases as the earliest sign. So these are cases you can see the retinal periphlebotitis. And these are other signs where you can see hypopyon and corneal infiltrates, keratic precipitates, fibrinous membrane in the anterior chamber along with hypopyon. So in endogenous ENDOF, apart from the post-op ENDOF, in endogenous ENDOF, we can also see pre-retinal hemorrhages and subretinal or choroidal abscess. So these also you should look out in patients who are suspecting endophthalmitis. So these are some cases where you could see a vitreous exudates and a subretinal abscess. In the endophthalmitis vitrectomy study, which was published in 1995, they have found that 94% of the patients reported blurred vision, 82% reported red eye, 74% reported pain, and 34% reported a swollen eyelid. And hypopyon was present in almost 85% patients, and media haze was seen in 79% of the patients, and 26% had presentation with the light perception only vision. However, there was inclusion criteria. There are some restrictions in that, and EVS had underestimated the severity of presenting symptoms and signs because eyes with significant anterior chamber opacification or without light perception were not included in the study. So in real world scenario, the results may not be of EVS may not be applicable in some situations. So one important thing is evaluation of vision in endophthalmitis. In EVS study, hand movement vision or better, we have to go for intravitreal antibiotics, whereas light perception, we go for vitrectomy direct. But we have to remember that light perception, hand movements vision in endophthalmic EVS study was done at a distance of 2 feet. So most of the time we do hand movements close to face, but you should remember it's at 2 feet, approximately 60 centimeter. Otherwise, if we measure it a shorter distance, may erroneously assign hand movement vision to an eye that is actually LP and could have in fact benefited from an early vitrectomy. So coming to indirect ophthalmology, ophthalmoscope examination, grading of the media haze, view, grade 1 is view of the retina is good. Vision will be around 6/12. Most of the time we see this in chronic endophthalmitis cases. And second order vessels, retinal vessels are seen in grade 2, grade 2 and grade 3. Some of the retinal vessels are visible and not the second order. And grade 4, there will be no retinal vessels visible. And grade 5, there will be no red reflex. So here you can see the optic disc is visible. So it will be somewhere around grade 4. And here, even the disc is not visible, it will be around grade 5. So severity of endophthalmitis, severe endophthalmitis will call when the projection of rays is inaccurate, there is RAPD, no fundus glow, or there are limbal ring infiltrate or abscess, and no response to intravitreal antibiotics in the first 48 hours. So these are some cases which can be considered as severe endophthalmitis. So next important investigation for endophthalmitis is ultrasound. So most cases who present with hypopyon in the post-operative period or any suspected endophthalmitis like a TAS or other different common differential diagnosis. Once you do the ultrasound, we can get a idea if the vitreous cavity we should look into the vitreous cavity, and it helps in confirmation of diagnosis of endophthalmitis. We can see dot-like echoes on V scan that can be multiple, scattered diffusely, or maybe localized to the anterior, mid, or the posterior 1/3 of the vitreous cavity. Usually the reflectivity, if you see in scan, it will be medium, around 10 to 60% height of the spikes. And there can be associated choroidal detachment, retinal detachment, retained intraocular foreign bodies also should be ruled out in cases of trauma. And then there sometimes can be membranous debris. You can pick up some membranes in the vitreous cavity. And again, loculated pockets can also be picked up sometimes, where there will be loculated with fluid pockets along with vitreous membranes and echogenicities. Coming to the systemic evaluation, most of the time, systemic infections like bacteremia, endocarditis, UTI, pneumonia, and abscess in the liver, spleen, or brain or lung, we should rule out, mostly in cases of endogenous endophthalmitis. Again, these are the different causes, systemic causes of endophthalmitis, which I have already seen in the previous presentations. And you can see this infection again mainly enters through the posterior segment vessels and causes a breakdown of the blood retinal barrier, and then it spreads to the anterior segment. So this is one case which presented with hypopyon and sudden onset diminution of vision. And on history, you could find that the patient had undergone some kidney procedure 2 years back, and once he had done, and so we sent these patients for investigation of all the systems, including ultrasound, abdomen, and chest X-ray. And then on ultrasound of the X-ray, we could see that there was a retained stent, which was done almost 3 years ago, and that was not removed in the patient. And urine culture had shown culture positivity, and then patient had infection with Serratia organism. So retained stents was found as one of the causes. Again, in endogenous end of systemic symptoms, we should look for fever, malaise, and sign of primary infection site. So this is one case which presented with retinal abscess and vitreous inflammation into our OPD. And this patient had cellulitis, and then on ocular examination, you could also see oral examination, candidiasis is also seen in this patient, and fungal growth was there in the culture. So these are the some of another closest differential diagnosis, which will be, I think, dealt in the subsequent sessions. So one of our patients which present with bilateral drop in vision and had one eye had left eye had uveitis, hypopyon, but there was no lead edema or any other swelling. So we suspected uveitis in this case, and we had gone and done a media clearing vitrectomy, and culture was negative, and then patient is doing well now. So there are some shortcomings of the EVS study because they have not taken, as I mentioned, some of the severe cases, and also the microbiological spectrum has changed over the last 30 years, and also advances in vitreoretinal surgery made vitrectomy more easier nowadays. So LBPS group with newer system of evaluation for endophthalmitis, which is known as endophthalmitis management study. So they give a score of 0 to 4 for 4 organs like cornea, anterior chamber, iris, and vitreous, for evaluation of patients with endophthalmitis. So this is the scoring, and based on the scoring, they have divided. So if the score is less than 10, you can go for a vitreous tap and intravitreal antibiotics. If it is more than 10, you can directly go ahead with vitrectomy. So microbiology diagnosis, this is the last part of the presentation. One of the ocular evaluation, once you do, you have to also send a sample for gram stain or GM stain. And culture can be from the aqueous, the yield is only up to 36 to 40%, and from the vitreous up to 70%. So we have to put the whatever thing we take from the aqueous or the vitreous, the sample into the aerobic or anaerobic media, and also for fungal culture into suburates dextrose agar. And positive culture is taken if it is at least semi-confluent growth on culture media, any growth more than 2 media or 2 culture media, and the growth of on media supported by a positive gram stain, and observe the plates for at least 2 weeks for because the anaerobic organisms might sometimes take long time to grow. So aqueous and vitreous step can be taken with a 30 gauge needle, and 0.1 ml of aqueous can be taken. Vitreous needle tap also can be done with a tuberculin syringe 23 gauge needle, and 0.1 to 0.2 ml can be taken. And vitreous biopsy can also be taken by using the suction cutting mode and suction using the manual aspiration into a syringe connected to the vitrectomy cutter line. And also during core vitrectomy, before starting the infusion line, you can take a vitreous biopsy. So there is an entity called culture negative endophthalmitis, which is seen more commonly nowadays. And so we can use newer advances in diagnostic microbiology like next generation sequencing, where the whole genome of the organisms can be sequenced, and they can also pick up both fungal and rare bacterial infections. And then there are some biomarkers like D-lactate, which are seen in bacterial infections, and also procalcitonin levels. This has been studied in various studies, and then found that this might help in predicting the risk of infection in culture negative endophthalmitis. And galactomannan and 1,3-beta-D glucan, these are found in fungal infections. So patients who are culture negative, we can go for next generation sequencing or bacterial biomarkers like D-lactate or procalcitonin, and fungal biomarkers like beta-D glucan and galactomannan. Thank you.